Kimberly Brophy. Kim is a registered nurse at the Scarborough Hospital for the past 4 years, and she's responsible as the project lead as the BPSO and an improvement facilitator with the Innovation and Performance Improvement team. Kim has lots of clinical experience and a passion for excellence in patient care. She graduated in 1982 with a diploma in nursing and began her career in critical care at the Hospital for Sick Children. In 1990, she transitioned from pediatrics to adult nursing at Markham Stouffville Hospital, where she worked in the ER. Her first leadership role was professional practice leader for the ER in 2004. In 2009, she completed her undergraduate degree, and in 2011 completed a Master of Nursing degree at the University of Toronto. Kim has an adjunct lecturer appointment at the Lawrence S. Bloomberg Faculty of Nursing, a certificate in Emerge and Geriatric Nursing, and is a member of National Best Practice Research Center. Today, Kim is going to talk to us about some of the strategies that the Scarborough Hospital has used to leverage their BPSO candidacy to support achieving targets on key corporate strategic priorities. She's going to tell us about the process that the Scarborough Hospital has used to ensure that BPG work is embedded in everything they do and not as an add-on. She'll discuss the process that the Scarborough Hospital has used to develop and implement tools such as a BPSO scorecard and a BPSO team accountability reports, and how they've used these tools and strategies to support sustainability. So I'd like to turn things over now to Kim, and again, there'll be an opportunity for questions at the end of her presentation. Thanks, Kim.
Thank you very much, Catherine. I just wanted to make a note here. I actually don't see the slides.
They should be on your screen, Kimberly, if you click on the tabs at the top.
Event Center, My WebEx.
So it should just say best practice, like your title, the title of the presentation.
Perhaps if I rejoin. I did have it and it was gone. Now it's gone.
If you look at the top of your screen, it should say Quick Start, Event Info, and Best Practice. Do you see those tabs?
Okay, I have it now. I just rejoined.
Wonderful.
Okay, I think you might need to make me give me control again, though. Oh, there we go. I'm just going to do it. Oh, yes, perfect. I think we're good to go now.
Thanks, Kim.
Okay, thank you so much. And thank you, everyone, for inviting me to present to you today. I'm very happy and excited to share with you the work that we've been doing at the Scarborough Hospital. Our session objectives for today are to learn how TSH has creatively embedded BPSO at all levels throughout the organization, present a measurement plan that tracks our BPG implementation and supports achieving organizational goals, and we're going to discuss how to develop processes and structures that support data collection and meaningful feedback. And this is our mission, vision, and values of our Scarborough Hospital. Our mission to provide outstanding care experience that meets the unique needs of each and every patient. Our vision is to be recognized as Canada's leader in providing the best health care for a global community. And our values are the acronym I-CARE, and that's integrity, compassion, accountability, respect, and excellence. And as we've embarked on our BPSO journey, we're really finding that there's a nice tight connection between our mission, vision, and values and our BPSO work. This is a little bit about who we are. We're actually 2 community hospital sites, and we have 6 satellite sites for dialysis. And our 2 sites are separated by 10 kilometers. So on a nice sunny day, you could actually run between the 2 sites, although not many people are doing that these days with the rain. We have 3,100 staff and more than 700 physicians and volunteers, and we provide a broad range of clinical services and programs, and you can see them all listed there. We're very much a full-service organization. And from our 2013-2014 fiscal year, just to give you a sense of our actual size, between the two sites, we have 491 beds. We have two very busy emergency departments and a very active birthing suite with almost 5,000 babies born in that fiscal year. Admissions, just over 28,000, and very busy operating rooms as well. And our nursing team that supports our work is just over 1,500 nurses in the RN, RPN, CNS, NP, educator, manager, director, and at our VP level. Our total direct care registered nurse workforce is just over 1,200, and we're very proud that the majority of the nurses are in the full-time category. We have 3 clinical nurse specialists and as well as 10 nurse practitioners on our nursing team. And the best practice guidelines that we're implementing, we have 8 altogether, and the 2 that are bolded in black, person and family-centered care, and the assessment and management of pain, these are the 2 guidelines that we're implementing across our organization. With the other 6, we're implementing in specific clinical areas. And this is a picture of our Nursing Week celebrations. TSH is part of Cohort 5, and we officially began our BPSO journey on April 1st. And in this picture, you can see us officially celebrating our candidacy. Rhonda Seidman-Carlson on the far right, and our RNAO coach, Althea Stewart-Pine, came to celebrate with us as well, and she is 4th from the right there. And this was a really exciting and happy day for us at TSH. But what's important to know is that the work really began well over a year ago. And TSH actually was unsuccessful in an earlier application to be a BPSO in the early 2000s. And some lessons that we learned from that experience included ensuring an organizational readiness to commit the time and resources to support successful implementation and a global understanding of what evidence-based practice is. And to get ready and started on the journey, the first step was to say what it is you're going to do. And for us, this came as an announcement at the RNAO AGM that our chief nurse and at that time president of RNAO, Rhonda, stated that TSH was going to respond to the next call for applications to be considered for the BPSO program. And there's nothing like telling more than 600 people that you're going to do something to get you mobilized into action. And so the work began, and to set the stage, the first step was to develop a plan. And for us, this involves the creation of a 5-year clinical practice plan that would inform and focus our work. For this clinical practice plan, there are 3 branches: evidence-based practice, an interprofessional model of care, and academic links. Best practice spotlight organization application and subsequent candidacy falls very tightly under the EBP pillar of this clinical practice plan. And then the next step was, once we said we were going to do it, we developed the plan on how we were going to approach the work. Is we had to commit some resources to actually do the work. And so at our organization, we have clinical practice leaders and clinical practice resource leaders and professional practice leaders. And these leaders all have a reporting structure to the particular departments that they're aligned to, for instance, medicine, surgery, critical care. And they also have a 20% reporting accountability to organizational projects. And so what we started to do was ensure that the 20% of the time, which is 1 day per week, that is organizational commitment, was aligned to BPG work and BPSO application. And this netted out to, it's easy to say, okay, 1 day of your week is going to be committed to this kind of work. However, in practice, this became much more difficult to have people actually separate out the time. And so what the request then netted out to be is 3.5 hours of dedicated continuous time per week that these leaders would be focused on BPSO work. And then the next step is getting busy with the work. And so we had to start where we were at in terms of evidence-based practice. And we started off with an environmental scan to see what was in place to support evidence-based practice, what was our understanding of it, and where was it actually in play or in use in the various clinical areas. And completing this environmental scan actually took a good bit of time. I led this work, and it took about 3 to 4 months to actually dig in deep to see where are we at with evidence-based practice. And it was interesting to note that our understanding of it was quite variable across the organization. And in fact, in some areas, individuals had no real clear knowledge of what evidence-based practice was, had no working definitions that they were utilizing. And in some teams, their notion of evidence-based practice was really focused on the implementation of order sets and felt that that was sort of the end of it at that point. And so what we did then was start some education sessions to support the gaps in knowledge and to get everybody talking the same way about what evidence-based practice is. And through pulling people together, talking about evidence-based practice, talking about the definitions, how it looks in different areas, we were actually able to create a sense of urgency among our leaders, our practice leaders and clinical resource leaders and others around how we could do better for our patients and how could evidence-based practice really advance our work forward. And so we started to prepare for our application. And here I just share with you a picture of myself this summer. I was fortunate to go on a trip out west, my first time to see the Rocky Mountains. And here I am, we did a backcountry hiking trip into Jasper. And on my pack, I have my hand sanitizer that I got at the Summer Institute. So thank you very much, Heather McConnell, for my hand sanitizer. And truly, I've done my best to get BPSO everywhere. But in terms of what we've done at TSH, we really focused some time on developing our BPSO elevator speeches. We really felt that BPSO was the way that we could incorporate evidence-based practice into the work that we do. And so we looked for the opportunities to talk about BPSO, discuss the guidelines, and be strategic in the guidelines that we selected. At this point, we engaged our corporate communications departments to help us develop a corporate communication plan. We did presentations to our leadership groups, and we wanted to have a tight connection to our clinical managers because on the ground, it's really the support of the clinical managers of their nurses in order to do this work is really critical to success. So we felt that we needed to have a tight connection to this group, and they needed to have a strong understanding of what our objectives were. And we also ensured that key questions that inform the BPGs were entrenched into everything that we do. And so what we did is we developed these questions, and we started to ask these questions every time a new project was brought forward, a new initiative was discussed, every time we were looking at policy and procedure or practice reviews. And we really wanted to look at what is it we're working on, what are the gaps or the issues that we're needing to address, what are the projects that are in queue that need to start, and what are the kinds of things that we would like to be doing for our patients. And then we really looked to expand out from our clinical practice group, but also to getting everyone involved. And so we had the formal commitment of our practice and professional leadership group with the 3.5 hours per week. But we also reached out to our Nursing Practice Council and to our nursing resource team, and we aligned them formally with BPGs. And we did this through focus groups, attendance at their meetings, and really engaging and seeing these individuals on the units and really engaging them in dialogue around BPSO and specific BPGs. And we also have our new corporate strategic directions that were just released in the summer. And what we found is that our having these priorities will really help us focus on what matters and transform what we do. And it's interesting that the work to determine what our new corporate directions would be followed a similar methodology to how we determined what BPGs we would implement. And what we did is we had focus groups. And so while we were having focus groups on the BPGs that were of interest to us, we were also having focus groups around our corporate strategic directions. And this really allowed us an opportunity to make further linkage and embed the BPSO work into the corporate directions. Because BPSO and the BPGs we were going to be implemented was well known, as we discussed and reviewed the criteria, CRLs and our other leaders were asking questions and presenting possible work that we would be starting on. And they were already starting to line this work up under the corporate strategic directions. And so consequently, we're finding that right from the broad statements of these corporate strategic directions right down to the clinical level where we're implementing BPGs, we're seeing really nice, tight alignment. And this will show up further in the presentation as we look at some of the indicators that we're following. Here's an example of one of our BPGs that we're implementing, and this is a corporate BPG, our person and family-centered care. And under our corporate strategic direction of patients as partners, we're really seeing that the one informs the other. So there's a reporting metrics through Enquire, but there's also corporate scorecard indicators that are focused on this particular BPG. So for Enquire, we're using the indicators of client satisfaction, treated with respect, feeling listened to, and teaching. And then a corporate indicator that we're using is tracking active patient involvement improvement and in improvement events and initiatives. And so for this particular BPG, we have a nice blend of a corporate metric and an Enquire metric. And some of the strategies that we're using to advance this work forward is we've just had our first meeting of our Community and Patient Advisory Council, and this council will actually help us advance the work even further. The other thing that's important is to measure what matters. In our data-rich environments, it's tempting to get caught up in measuring everything, and because there's lots of things that we can measure, there's lots of things we want to know about, and there's lots of data that comes at us from different sources. But just because we have a lot of data on a certain type of metric performance indicator, it doesn't necessarily mean that it's useful information. And so as we have been selecting our metrics, developing our scorecards, we've taken this opportunity to look at what are the things that we really need to be focused on. And so these are the questions that, as we've decided on metrics to measure, these are the questions that we've been asking ourselves. What is it that we really need to know? So what is mandatory reporting? What do we already measure? And are the things that we're measuring, is it really useful in helping us in the work that we're doing? What is important to the organization? And so are there things that, is there information that aligns to corporate goals? And how easy is it to get the data? And in fact, this has been one of our stumbling blocks as we've moved forward with trying to develop our databases and our measurement plans, is some of the things you think are really important to measure and really would be helpful, sometimes the data isn't quite so easy to get your hands on. But an example of a BPG measurement plan that's in place right now is for our breastfeeding BPG. There's two Enquire indicators that this team is using, and one is exclusive breastfeeding, no formula during the hospital stay, and the other is rates of formula supplementation. So in terms of the four key questions, this particular BPG actually meets three of their criteria. This is important to TSH that we increase our exclusive breastfeeding rates because TSH actually is seeking baby-friendly status. And in order to do this, you have to meet certain requirements in terms of breastfeeding and rates of formula supplementation. Because this is an initiative that was already underway, we were already measuring this data and collecting a lot of information on it and reporting this information through the BORN initiative. And consequently, it was very easy for our BPG co-leads to get access to this kind of information. Unfortunately, it's not a perfect solution. These two indicators that we've chosen are both outcome measures, and we were actually looking to see if we could find a process measure that we could measure as well. But unfortunately, because the practice areas, our maternal child areas, use paper-based charting, we're actually not able to pull the information that we need for the process indicators. As much as possible, electronic sources of information are easier to get and also tend to be more comprehensive. To do manual chart audits just isn't something that we have the resources to do, and so we're not able to actually measure a process measure for this particular BPG. But another example is our caregiving strategies for older adults with delirium, dementia, and depression. And here there's two NQuire indicators that the team is measuring, baseline cognitive function for patients 65 years and older, and changes in cognitive function while in hospital. But we were also able to incorporate a QIP metric here, and QIP is the Quality Improvement Plan. And this is the completion of the CAM for patients 70 plus. It's important to know that the QIP metric, this is actually a mandatory report that the hospital has to do. And so for this particular BPG, we actually meet all four criteria for the key questions. We were already measuring the QIP, and so it was just an easy adjustment to the data that we got in order to meet the NQuire requirement. This information is important to TSH because it's mandatory reporting. It's easy to get the data because there's already an electronic process in place to gather it. And as I said, it's mandatory. It's a mandatory measure. Another example is through our developing and sustaining interprofessional health care. Now, this is not a corporate BPG. However, part of our sustainability plan will be to spread this particular BPG across the organization. But we do have a couple of metrics here that are really important to our corporate strategic direction, as well as this BPG informs one of the branches of our clinical practice plan, which was the implementation of an interprofessional model of care. The indicators that this particular BPG is going to measure are the number of patient care units that have implemented an interprofessional model of care and the percent of units that implement core teams. And this satisfies two of our criteria. It's important to TSH that we implement this interprofessional healthcare model, and it's also easy to get the data on these particular measures. Now, in terms of data collection, as I mentioned with the breastfeeding example, electronic is as much as possible is the way that you want to go. Anytime that you have to do manual chart audits, you're investing an incredible amount of time and resource to get that kind of information. The other thing to consider as well is frequent intervals for data collection allow for timely responses. For some of our data, it's collected on a quarterly basis, but you can imagine when you're doing some work with your patients on your clinical unit and you're getting information that's 3-4 months old, it's very hard to remember sometimes what the state of the situation was, what was the context, what was happening that influenced what we're seeing in the data. And so it's hard to know what are the changes that we need to be making. And so as much as possible, we're looking for data sources that can give us really timely access to current information. And as much as possible, we're working to get weekly data on information. And this has involved reaching out to our decision support and to our clinical informatics teams. And these particular groups are very used to providing information up to our senior management team, to our board of directors. And it's kind of a new thing to get this sort of information down to the level of our clinical teams. But because of our strong communication plan that we had put in place at the very beginning of our journey, these requests didn't come as a surprise, and our colleagues in decision support and informatics actually already had some really great ideas on how we can actually get the kind of data that we need and in a timely way. And if we take one of our BPGs as an example, we can look at our assessment and management of pain. And for this particular BPG, we're using 3 NQuire indicators to monitor our progress. And the indicators are screening on admission or initiation of care, screening for pain once per day, and patients indicating a presence of pain using use of a valid and reliable tool. And in terms of the criteria that the litmus test we use to check if we're on the right track, we can actually get electronic reports on this, and we can get this on a weekly basis. And so this is really going to help our implementation of the recommendations on the specific units, because we can pull weekly a report that will tell us how we're doing, how we're tracking to these indicators. And being able to feed that information back to our teams on a weekly basis really will help them to see what's going on, what happened on Monday, this is Friday, what happened Monday that influenced our inability to actually get these assessments done. And then the teams can then put action plans in place to address the barriers. So in terms of feedback and reporting, we're a lean organization, and so we're really looking to leverage a lot of the visual management tools that we have adopted through lean to support our reporting. And when you're giving feedback, you want to tell everybody what you're doing, but you also want to let everybody know how you're doing. And we've really worked hard at Scarborough Hospital to create a culture of openness around performance. If we're not tracking well on a specific indicator, this isn't seen as something that is punitive, as an indication of low performance for a team. This is really seen as an opportunity for quality improvement and what can we do better. And so we're very open with sharing data across the organization, sharing performance of teams across the organization. And as much as possible, we try to make it visual. And I'm going to show you a few examples of how we've actually been able to do that. And the feedback and the reporting loop has been built upon existing reporting structures that we already have. As much as possible, you want to see what you already have in place and leverage that and get those committees, those teams, those groups looking at the things that you're looking at and the things that are important. And where there were gaps, we look to create new reporting and feedback loops. Excuse me. And here you can see our BPSO reporting structure. Oh, pardon me, I'm getting a bit dry. And so you can just see that it might not be too clear, but you can see that our BPG teams, clinical resource and practice leaders and champions are the foundation for our work. This feeds up into our BPG teams, and then the BPG teams, of which we have 8, all report into our corporate steering committee. Our corporate steering committee has some ad hoc members. We've been fortunate to have our clinical ethicists sit with us at that table. Our corporate communications has joined us. We just recently received information that our project management office also will be supporting the BPSO work. I think this is another indication of how we've been able to integrate BPSO throughout the organization. When you say BPSO at TSH, people really sit up straight and take notice because we really are everywhere. And we're also, as a next step, we haven't yet, but with the newly formed Community and Patient Advisory Council, we're looking to actually include a member from that council on our BPSO Corporate Steering Committee. And we're also looking to embed a patient representative in each of our BPG teams as well. And then you can see the Corporate Steering Committee reports to Rhonda Seidman-Carlson, our Chief Nurse, who then has reporting to our Board of Directors, and she reports twice a year to the Quality Committee of our board. And she also reports to our Senior Management team on the status of the BPSO project overall, but also the progress of the implementation teams and how we're tracking to our indicators to the Senior Management team. And that's every 7 weeks that she does that report, as well as our direct link to RNAO with our reporting accountabilities there. And so with this structure, it's important that we get the information to flow. And what you can see here, this is actually a picture of the Athabasca River from from my trip in Alberta. And this is quite a mighty river. It's big, it's wide, it's very strong. And I'm not quite sure where the source is, but as it moves through all these rocks, it cuts new paths and creates quite an impression on the landscape. And with our flow of information, this is what we're trying to do as well. And so to support the flow of, which is the starting point for us in all of this, was to create the overall BPSO project charter. And then each BPG team has developed a project plan with timelines. And embedded into these plans are the required reports. And ideally, we've assigned one person with accountability for the reports to ensure that things are completed on time. Another key point to keep in mind is that you need to tailor the report to the audience. There's different groups that need to have different kinds of information. And here's just another visual to show how the information is flowing. And if we look to the far left and see the clinical interface, this is really where the information starts. This is where the BPGs are being enacted and enabled. And this is where we see, are we making a difference? And from there, we want that information to flow to the BPG teams, and then to the Corporate Steering Committee, up to the Senior Management team, and to the Board of Directors. And when I talked about visual management and us being a lean organization, this is where we've leveraged some of the structures that we already have in place. And this is how we make a lot of our information visual. This is an example of a clinical team's Huddle board. And you can see that it's divided basically into two sections, alignment and engagement. And the engagement side is really about improvement opportunities that are made on a day-to-day kind of basis. These are small-scale, sort of 3 steps or less sort of improvement opportunities. But to the left-hand side where you see alignment, this is where we have the corporate strategic direction, and this is where the indicators that we've chosen, why it was so important that as much as possible we link them to the corporate direction, because this is posted on the board. And so we would then put up the data showing how the team is tracking to a particular metric and how it actually supports a corporate strategic goal. And this is where we would post our weekly information on how the team is tracking. And this is just a breakdown of how some of that information might look. And so what we have is a run chart. Run charts are very easy to create, and you can see on the one that we have there, we've got green, yellow, red. This makes it very visual with the line going across to see, are we in the green? Are we tracking to where we need to be with this particular indicator? Are we yellow or are we in the red? And the goal is that you can know at a glance how the team is performing to a particular indicator within 10 seconds and from 3 feet distance from the board. And many of these Huddle boards are also in very public areas, and so our patients and families actually can see as well how a team is progressing on certain indicators. Our next step actually with the Huddle boards is to, while we have indicators under the corporate strategic direction, we're also going to have magnets or logos that also identify BPG-specific indicators as well. One of the other tools that you see on the screen here is the fishbone diagram. And so if a team is performing red on a certain indicator, the next step then would be to look at what is the root cause analysis, and we use these fishbone diagrams to help uncover what are all the things that are contributing to this particular indicator not performing as it should. And again, this is very much an open culture of sharing and with a goal towards quality improvement. And so teams are very open about having this sort of information displayed on their boards and having conversation around this when they have their huddle. And once we do the fishbone, then we have to put an action plan into place. And on the left is just an example of what an action plan might look like. And on the far right, you'll see what's called a Pareto chart. And this is where we might uncover what is contributing to a certain indicator not performing well. An example might be perhaps not having enough time to enter information into the chart. And so we would track what are the things that are contributing to not having enough time. Is it the timing of report? Is it people arriving late for shift? Is it returning patients back to bed after they've been put up into chairs? So we look to see what are the trends and then see what are the things that we can action and use to develop an action plan. So what we're really trying to do here is say, we're going to put indicators up, we're going to measure how we're tracking to our performance, and then we're going to do something about those things that we're not performing where we feel that we need to be. And here's an example of our Huddle board for our senior management team. And you can see that it looks very different from that picture that I showed you earlier. And this is because we really need to tailor the information for the audience. And so at the clinical level, the team Huddle board is going to have that weekly data, the day-to-day, what's going on, what are our barriers to really being successful with our implementation of the BPG. But at the senior management level, they're not so concerned with what's happening on the day-to-day on the unit. They're looking more at what's the monthly performance towards the indicator, what's our quarterly performance. And so what we see at the senior level then is a more broad view of how the BPSO project is performing, and we see the indicators, a sum of all of the teams that are focused on one particular indicator. So we would see breastfeeding reported as one indicator as opposed to broken out to multiple sites. And another example of how we're tailoring the information, this is a tracking sheet that's based on key milestones. And what we've done is incorporated the reporting and accountabilities and the knowledge to action framework, which we're using to support our implementation plans. And this guides a monthly check-in with the BPG leads. And so the BPG leads know exactly what is expected for the quarter, what sorts of milestones need to be achieved, and how are we tracking to successfully achieving them. And this particular tracking sheet, this is posted at the Professional Practice Huddle. Actually, I'll be heading to that huddle right after this presentation to actually present this particular chart, showing that we have most of our team, or all of our teams are green in terms of the key indicator that they're supposed to be meeting for Q2. However, we have one team that has not achieved their milestone, and so I need to give a report on why that team is not able to achieve, not able to be successful in that particular milestone. We've also taken this particular tracking sheet and used that to help develop a BPSO scorecard. I just have a draft of that, so I'm sorry I can't share that with you today. It's a little bit of what Rhonda calls a hot mess, but it's almost in its final stages, and I'd be happy to share that if anyone is interested in it. You can just send me an email. But with the scorecard, again, this takes the information, pulls it all together and summarizes it so that this then can be fed up to the board of directors, the senior management team, but also to any external stakeholders that might be interested to see how we're tracking towards our success. These particular documents, like our BPSO scorecard, these are also things that we'll be posting on our external website so that our patients and families in our community can also track to see how we're doing with our success with our BPSO implementation plans. And just to close off, there's this one quote that I found very helpful. They always say time changes things, but you actually have to change them for yourself. This is from Andy Warhol, and it's very true that this sort of work doesn't just happen on its own. There is some organic spread that will happen just because people like the BPSO work, the BPGs speak to them, they make sense, they'll pick them up and use them. But focused change really does require focused work, and you really need a team that's working towards a common goal. And I think at TSH we're well on our way because we've been able to spread the BPSO across the organization. Our CEO understands what it is. He can speak to the acronym. He talks about it in his updates to the board, to the community, to his town halls that he has with the organization. And I think that that is a real measure of success of how we have really worked very hard to embed our BPSO at all levels of TSH. And so with that, I thank you, and I welcome any questions that anyone might have.
And it's Catherine here at RNAO. I just want to thank you for a wonderful presentation. I think you've done a great job at just highlighting the processes, the infrastructure that's been developed at the Scarborough Hospital to successfully implement the guidelines, and really that will support you in sustainability. Yes, again, we want to have some discussion. There's so much that Kim has shared with us that they're using at the Scarborough Hospital that I think can be so helpful for other organizations. And you're welcome to send her a question just using the all panelists on the chat box. What I noted, Kim, was just the how the organization has chosen to align the BPG work with other strategies, and by doing so, leveraging it to give it importance, to give it prominence in the organization. As you talked about, just aligning it with the corporate strategic directions. I think that's so impressive. I liked how you talked about the transparency of reporting and making it visual, which I think then engages people because otherwise it can look like a lot of numbers and data. I wondered about, you started off just by talking about that you ran education sessions and that you focused initially on just what is evidence-based practice to make sure that everyone knew what the term meant. So I'm just wondering about following that, how you've educated staff so that they're aware of the BPGs, the recommendations, and really how to take that knowledge and apply it at the point of care. Can you speak to that a little bit?
Oh, absolutely. In terms of informing the organization and establishing that foundational knowledge, we really started with our clinical resource leaders. And in some hospitals, these would be like practice leaders or perhaps nurse educators. And these were predominantly nurses. And we found that this was a key group because they had a strong connection to our clinicians. And so getting that group educated, comfortable to talk about evidence-based practice was really key. And getting them to see what was evidence-based practice already in place, what wasn't, and what people thought was evidence-based practice. And so that really started the conversation at the clinical level with teams, talking about, okay, why do we do this? Is this something we've always done and we just do it because we don't know any differently? Is this something that we do because so-and-so said it was a good thing to do? Or is this something that actually was brought in very purposefully and does support the criteria to be evidence-based practice? So it was really about starting those conversations. And that really put us in a good place when we started to have the focus groups around what BPGs would we implement. The nurses were then coming to the focus groups with questions about evidence-based practice. How does a BPG satisfy the criteria for evidence-based practice? Will we be practicing according to evidence if we put this BPG in place? And for some of the teams it was, oh my goodness, how can we not do this? Because the way that we're doing it now really is not the best thing for our patients. And so for us, it was really just getting the conversation started and being strategic about who we started the conversations with so that they could continue.
Thanks for that, Kim, and I think also speaks to having an environment that you mentioned transparency, that where it's fine to ask questions, and so valuable just to really be very clear about what evidence practice is and isn't, because you might have had staff then that just thought it was solely nursing order sets and not having a more broader understanding of really what it is. We have a question from Kathy just asking, will this presentation be available on our website? The answer, thanks Kathy for that, is that yes, it will be. We're just working currently with our IT department to create a new link for the webinars that we've just recently started to archive. And you should know that for all of our presenters, we do ask their permission to record the presentation and record the slides as well, so that those are made available to anyone. And I think there is so much here that all of us can learn who are engaged in BPG work implementation and the BPSO process. Another question for you. If you were trapped in an elevator with a senior leader in your organization, what would you want them to know about BPG work? What would help to tell the story? And I think you've given so many examples just using the guidelines and the indicators, but how do you engage them?
I think that as clinicians, we really need to be comfortable to talk to the senior team about how is the work going at the clinical interface. What's happening when I talk to my patients? And this is really about getting comfortable telling stories about how you're doing with BPG implementation, what's happening, what's going well, what are the success stories. And then we also want to be able to tell them what are the things that we need in order to really advance the work forward. If we're looking to have the weekly measurements and information on how we're doing, then we really need to have systems in place that help support us to do this. And it's by engaging the senior team and knowing what is it you need. They're the people that can pull the levers to make those kinds of things happen. And so I really encourage anyone who's on a BPSO journey or wants to make any kind of change, really think about these elevator speeches. If you had 2 minutes with the senior leader, you really want them to know in a concrete way what you're doing. You want to have that compelling story that will capture their interest and help divert their attention away from something else so that they can be looking at what you're doing and support the work that we're doing at the clinical interface. I think that we can get really distracted by finances and operations and flow, and all of these things are very important, but it all supports the patient's story. And so I would encourage you to really think about what is it you're doing, how can I tell this to the senior team so that they can then focus and support the work that I'm doing.
And having, with that example, thanks for that, Kim, just having a staff that is very engaged in this process as well, and again, having an environment such that someone feels comfortable to share their examples, what's working and what isn't. I'd like to also, you talked about that some of your scorecards, some of that data is made visible then to patients, to their families. What kind of response have you had from them?
Often they'll just say, what's this? Why is it red? Red gets everybody's attention. So I find that they're more likely to comment on the colors and ask why. Why is that red? And we've been posting stuff on these Huddle boards, for instance, our falls rates, restraint use, pressure ulcer incidents. This has been on our board since we start putting them into place. It would be about 3.5 years now. And so the red grabs people's attention. They'll ask, why is it red? And it's an opener for a conversation that to have with the clinicians around, well, why do you measure it? Why is it up there? What are you doing about it? And that seems to be what patients and families really want to know. That's red. What if, and what does that mean for me? And so they want to know, what are you doing about it? And you know, we're finding that our teams are really interested to share that kind of information. They're not afraid to say, you know, it's red because of this, because the next sentence is, this is what we're doing about it. And this goes back to what we're posting, the culture of transparency. It's not okay just to put some numbers up there and walk away and not have an action plan to address anything that might be an issue. And so the teams feel really confident to say, yeah, we're red, but this is what we're doing, and this is when we expect to be green.
Wonderful. And I have one more question, and again, I'm just waiting if anyone else has questions for Kim. I'm just wondering, as nursing best practice guidelines, how has the implementation really promoted nurses at the Scarborough Hospital? How do you think they have they felt that it has improved their working lives, their relationships with their with patients, with interactions with physicians, with other medical staff? What impact?
Oh, that's actually a really good question. We're still pretty early in our journey. We're just past the 6-month mark. And our work has really been focused on developing the structure and the processes because, sadly, our VP, Rhonda C. McCarlson, is retiring in 4 short weeks now. And we really felt that this was a threat to the continuation of the project. Anytime you have an executive sponsor for a project leave, you know, your project could be in jeopardy. So we felt that we really needed to focus on developing those structures. Our next few months now is where we're really going to be taking the work now down to our champion development and to the nurses to start our implementation of the specific recommendations. So we're right on the verge of starting that kind of work. And as you're saying that, I'm thinking, gee, I wonder if we can measure that in any way. And so I think it's a really good question to see how can we measure the change in terms of the implementation of BPG's evidence-based practice, the change to nurses' work life, their engagement with colleagues, and their feeling of ownership and accountability for the BPGs. So perhaps that could be my next presentation with the knowledge exchange.
Perhaps captured in a staff survey, but certainly that can be very rich data. And again, promote just that leadership and ownership within the nurses at the Scarborough Hospital.
Yeah, absolutely.
Yeah. Well, I'm not seeing any other questions for now, and then you've indicated you have another meeting to go to. So let me, on behalf of everyone in attendance, Andrea and myself, just thank you again, Kim, for your time and for sharing all of what the Scarborough Hospital has learned and all the processes it's put in place to support BPSO work. We are proud to have you as one of our partner organizations in BPG implementation. So thank you so much for that, and again, thanks everyone for attending. We will have another webinar in December. We're going to be focusing on the Baby-Friendly Initiative as an implementation strategy. So please join us December 9th from 12 to 1. So thank you again, Kim, and again, thanks everybody for your attendance today. Thanks.
Thank you.
Bye.
Bye-bye.